So way back in 2020, and actually was lucky enough to be at the consensus panel. It wasn't just radiologists. There were hepatologists on there. There's a variety of doctors. So it was pretty much people that would interact with the patient were there. There was even a pathologist there. So, you know, it was a good representation so that we could say, hey, here's what we think in radiology, and then have the clinical people say, no, 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 that's not what we want. We need to know this information. So basically they told us it's more important to rule in or rule out significant disease than get that exact stage by using the Medivir scoring system. So it was decided that the detection of compensated advanced chronic liver disease is really important. So that would be one of the main goals. So the guidelines were revised based on the probability of chronic liver disease, advanced chronic liver disease for the given stiffness values. So here's that new chart, and it's in both kilopascals and meters per second. So, you know, if the patient's values are lower than this, they have a normal liver or a very high probability of no or maybe even just mild fibrosis. In the absence of other known clinical signs, this was a compensated advanced chronic liver disease. If there are known clinical signs, they may need further tests for confirmation. So here we got like those gray areas. So we're less than 9, obviously greater than 5. And then we get greater than 9. So between that 9 and 13 kilopascals or 1.7 to 2.1 meters per second. So that's a, yeah, there may be that compensated advanced liver disease. So we may need to do some further testing. But here, when we get to this point, greater than 13 kilopascals or 2.1 meters per second, we can sort of say pretty confidently that yes, there is compensated advanced chronic liver disease. And then if we go way up here over 17 kilopascals or 2.4 meters per second, again, then we can say with the confidence that we have clinically significant portal hypertension. So again, here's some nice normal tissue here. And so blue's way down here at the bottom. Then here we got some light blues, aqua blues. So like right in here. So sort of mid-range. So again, this could be suggestive and they need some further testing. And then here we have very high values here in a patient that will have portal hypertension. So why are there 2 units? I think this confuses clinicians a lot. So like Pascal is a unit of pressure because that's force per unit area. So it measures the tissue stiffness of the liver. So the FibroScan could only report in pascals. That was what they were limited to. So when we finally started getting, you know, RFEs and all these other visual under ultrasound values, the FDA said, oh, you're measuring meters per second, so you need to express your information in meters per second. You know, you're not measuring pressure here. So they sort of forced the ultrasound community in the beginning to report in meters per second. Fortunately, the ultrasound community like revolted and said, look, all of our charts, all of our information is in kilopascals because this is where it came from, was the FibroScan. You know, it's difficult for us and clinicians to say, you know, this chart is in kilopascals, but I got meters per second. What does this mean? So, you know, it took some fighting, but it actually happened very quickly, which surprised me with the FDA. So then they allowed, you know, when we have visual ultrasound to do the elastography, they then let us do it in kilopascals. So high value kilopascal means very stiff, as well as a high value in meters per second. So now we got some cool stuff going on. You know, I think this is what's so exciting about ultrasound is we don't just stop here it's like, well, we still have these issues that we're dealing with, elastography is pretty good, but there's still some false positives and false negatives, and people that are on the gray zone, so we need to find ways to really help our patients get a more accurate feeling of what's going on with their livers. So then we started measuring the sound speed through the liver, the attenuation factor, and the viscosity. So this was giving us a lot more information. So again, we talked about attenuation, what's happening. So again, this can really give us an idea of how much fatty liver is in there based on how much the sound beam is being absorbed in that tissue. And the viscosity looks at the inflammation of the tissue that's going on. So sound speed is an ultrasound-based method that allows liver fat assessment by estimating the intrahepatic speed of sound through a fixed region of interest. So basically, like I showed in the beginning, you got normal liver 1540, then you got fatty liver starting at 1570. But the machine, when it does things, everything is calibrated to 1540 meters per second. So this actually gives the ultrasound unit the ability to measure the actual speed through that liver. Again, not assuming it's 1540. And again, that sort of helps us again, because faster speeds mean the liver stiffness. And then the attenuation mode, again, we've talked about, it's going to tell how much of that ultrasound beam is being absorbed in that area of interest by measuring the decrease in the amplitude of the ultrasound waves as they propagate through the tissue. Because those waves are going to get smaller and smaller, that amplitude as they're absorbed. Viscosity describes a fluid's resistance to flow. So something like maple syrup is thick, water is thin. So the liver tissue exhibits these viscoelastic characteristics. It's a propagation of shear waves, depends on both elasticity and viscosity. So even though we were ignoring it in the beginning, we're coming to find out that, there's some other things going in here besides stiffness. So NASH, or non-alcoholic fatty liver disease, or acute hepatitis, all of these things increase the viscosity of the liver, which may affect stiffness assessment. And as we know, inflammation plays an essential role in developing fibrosis. So this viscosity is just another tool in our toolbox, and it's obtained at the same time as doing the elastography traditional methods. So there's no special thing that needs to be added to. It's the same acquisition protocol. It's the same probe. It's just that the software inside the machine sort of takes this information and gives us it into two different ways. So the viscosity is going to analyze the propagation speed of the shear waves at several frequencies and delivers information regarding the tissue shear wave dispersion. So this viscosity takes that information and helps, here's what's going on with the viscosity of the liver. So this allows display of information about the tissue shear wave dispersion. Again, this can serve as an indirect method for measuring viscosity. So they're not really measuring the viscosity, but looking at this dispersion to help them transpose it into a viscosity reading.